Welcome to the Lifespan Connections Lab. These episodes are being brought to you by Lifespan Cancer Institute in partnership with the Gloria Gemma Breast Cancer Resource Foundation's Passport to Survivorship. Because of the COVID-19 pandemic, this year's Passport to Survivorship is being brought to you virtually. But all of us are committed to bringing you top-notch education as tools to support you during your journey with cancer. Throughout the year, the Gloria Gemma Foundation receives many questions across a number of topics. We have decided to take 5 of the topics to help answer some of those questions in this year's Lifespan Connections Lounge. In our first episode, we welcome plastic surgeon Dr. Rachel Sullivan, who will be discussing the different types of reconstruction available to patients.
Hello, my name is Rachel Sullivan, and I am a board-certified plastic surgeon who does breast reconstruction after mastectomy. Today I will be discussing the basics of breast reconstruction and covering further questions if time allows. There are a number of types of reconstruction. The 2 main common pathways to reconstruction are either implant-based or using a patient's own tissue, which is called autologous tissue. Implant-based pathway involves either use of a tissue expander, which then can be switched later to an implant, or sometimes direct-to-implant reconstruction at the time of mastectomy. Autologous tissue, in the same vein, can be done either at the time of mastectomy or can also be after a tissue expander has been placed previously. And to make it a little more complicated, use of autologous tissue can also be done with implants and tissue expanders at a later date as well. What is a tissue expander? A tissue expander is a temporary implant. It is different than the final implant. It is saline filled, and it is used to stretch the skin or preserve the breast pocket for later reconstruction. Implants are the final implant, and they can be either saline or silicone. This difference is based on what fills the implant. The shell is always silicone, so it's just a matter of whether it's filled with saline or a silicone gel. There are also shaped or round implants. There are also smooth or textured implants, and that is talking about what is that outer shell made of exactly. Monitoring of implants is very important. Typically, plastic surgeons after reconstruction will follow their patients on an annual basis. Implants can rupture, though the incidence doesn't really start to go up till about 10 years out. And if there are any concerns, the monitoring is typically done by MRI or ultrasound. However, routine screening mammograms are not necessary in a reconstructed breast for breast cancer screening. So autologous tissue, which again is use of the patient's own tissue. There are 2 main types of this kind of flap. There is the pedicled flap, which means that the tissue has been kept attached to the patient. And the 2 most common flaps of this type are the latissimus dorsi flap, which is from the back, or what's called the tram flap, which is from the abdomen, and that stands for transverse rectus abdominis myocutaneous. The other type of flap is a free flap, which is where the tissue has been cut off from its blood supply at its origin and needs to be hooked back up in the breast area. The most common type of flap of this sort is the deep flap, which stands for deep inferior epigastric perforator. And this is a variation of the tram flap. Timing. So people can choose to do this at the time of mastectomy, which is called immediate, or they could do it in delayed fashion. And this can be done whenever. Reconstruction never has a limit. It can be done at any point. There's never a time when people cannot proceed. They can just do it when they're comfortable. Considerations of how and when to proceed with reconstruction. There are a number of considerations to be taken into account. Whether somebody's going to need chemotherapy or radiation is a very important factor into type and timing of reconstruction. Patients who have had or will need radiation can definitely have reconstruction, but it certainly factors into the results and also limits the options for those patients. Body habitus, when you're evaluating a patient, looking at their weight or their BMI, or looking at the breast size, or the ptosis, which is the medical term for the sagginess of the breast, or if you're looking at skin quality. These are things that go into consideration of what is going to be the best type of reconstruction for a patient. Unilateral versus bilateral. Unilateral means one-sided breast reconstruction. Bilateral means both breasts. So this factors into how the best reconstruction is going to be for the patient. And ultimately, a patient's desired outcome is a very important factor into what's the best way to proceed. After reconstruction has been done, there are also a number of procedures afterward. There could be nipple areolar reconstruction. Often patients will need revisions of that reconstructed breast. Additionally, contralateral procedures, which means reconstruction of the opposite breast when somebody has elected to have unilateral reconstruction, meaning one-sided reconstruction. We can do procedures on the other breast to try to bring that patient into better symmetry. And that can involve a breast reduction, a breast lift, breast augmentation, or a combination of a breast augmentation and a lift. A common question I get from patients is, will my insurance cover this? And the answer is yes. The Women's Healthcare and Cancer Rights Act of 1998 ensures that when a woman has opted to have a mastectomy, that she can have reconstruction of all sorts, including initial reconstruction and revisions, as well as contralateral symmetry procedures. And this is mandated to have coverage. Thank you for listening to me today. I will be discussing questions that were sent over via the social media. So one of the questions was, what are the differences between types of implants? Again, there are a number of different kinds of implants. There's different sizes, there's different profiles, there's a different fill to the implants, there's different shapes and different quality of the outer shell. Again, this is a conversation to have with your doctor as to what is the best fit for you. If I have had reconstruction, what happens when I go for my future mammograms? Again, on a reconstructed breast, you do not need to have mammograms. But say somebody does opt to have just unilateral reconstruction, they still should keep up their mammographic screening on the native breast. How long do implants last? There's a lot of information on that, and it's based on different implants. So there's 3 main implant companies within the country, and they have different percentages. Ultimately, the idea is after 10 years, the rate does tend to go up, though it's still small, so it's very important to just monitor the implants, and if you can identify a problem, then it's reasonable to return to the OR. What is the difference of having partially inflated or non-inflated expanders? So again, the expander is a temporary implant, and some people may not be able to have any inflation at the time of reconstruction, so it would be non-inflated, meaning there's no saline at all in it. Partially inflated means that you were able to put some saline in there. And partially inflated is the state of that expander until you can get full inflation and then get the patient to the next stage of reconstruction. Is it ever too late to have reconstruction? Nope. People can do reconstruction whenever they're ready to proceed. If you have had radiation, can you have reconstruction? And the answer is yes. People with radiation absolutely can have reconstruction, but it can affect the outcome and also limit the options to the patient. So again, this is a good conversation to have with your doctor as to what are the best ways to proceed.